deliver radiotherapy in post-operative phase. This is the limb salvage protocol. We deliver 3 to. We did the surgery, removed the entire bone after shaving it off the tumor and the muscles. Only the bone came for radiation. As I told you, we can't treat the limb because of the late toxicity anticipated. So 50 grays delivered in 25 days. Like for cervical cancer, we deliver such a dose over 5 to 6 weeks. So in a single sitting, we delivered a very high dose, but only to the bone, and bone is very resistant. Bone is very resistant to the boy, and it will be very difficult for you to tell which leg was operated. So, and fortunately, he is doing very well, still under local control and condition. A lot of pitfalls associated with these techniques. You need to draw your target properly. In previously conventional techniques, you just open the field and treat, fire and forget. You will not miss the tumor. But surgical oncologist, and then with their help, because they have seen the tumor, we need to draw the tumor precisely. And one of the important investigations which help us in tumor delineation, and sometimes it reduces our target. Just to see if this head and neck cancer patient, so this is the volume we have drawn. But if you see the PET scan, this is the head and neck cancer. We may in our haste miss the tumor here or the node, but if you see the PET CT scan, very clearly the node will be delineated. So PET-based planning nowadays is very important. This is the case of cervical cancer. The nodes will be very clearly visualized, and you will never sure miss these tumors. So yes, PET CT scan has made a lot of difference as far as the radiation, gynecological malignancies, esophagus cancers to deliver the treatment. So this is another important form of treatment in some of the tumors. So just to summarize, radiation delivery, which we use to deliver radiation to the highly super selective precise radiotherapy, where we try to sculpt the dose around the target and save the. Now there are a lot of opinions, such as somebody saying I will operate, medical oncologist may say I will start with chemotherapy, radiation oncologist says no, first radiation is required. There is a lot of confusion on the part of doctor as well as the patient. What usually we have seen operated outside, margin comes positive. Then the patient has to again undergo surgery, revision excision as well as axillary clearance. So it's very important to take some time, discuss with your colleagues, and then a proper treatment should be started. So on oncology, the first treatment is very important. In other patients, obviously we do surgery first. So each and every treatment has to be individualized, and this is very important. This is basically the basic crux in oncology, and whenever we are in doubt, always we should consult a specialist. We should consult a team where there is a concept of tumor board. Tumor board basically, or joint clinics, are multidisciplinary meetings where all the oncologists,
you have a lot of colors, you have a lot of animations, so it makes it all the more interesting. It was easy to understand. I'll give you a holistic view as a neurosurgeon. The best modality, obviously in my opinion, is that you go after the tumor. So if you are able to excise a large cell-based lesion, the tumor is gone, the patient is cured. Take the instance of meningiomas. Let's say you're treating a large anterior cranial based meningioma, you remove the tumor, the patient is cured. Take the instance of very large pituitary adenomas. You go in once, well, you're not able to remove it, go after some time again.
Yes.
You might be able to remove it. So this has to be seen in the context of a holistic view.
Yes, that's what
So let's say, Amritsar, there is some invasion into the cavernous sinus, the tumor is tough, you're not able to take it out. Okay, then gamma knife would be a suitable modality. Another problem is that to the best of my knowledge, malignancies in brain have not been, they're not very friendly with the radiotherapy concept. Obviously, in a young female, the question of facial nerve, and we in private practice, caustics, small, gamma knife would be a effective modality. So that's it. I think wonderful lecture. I must congratulate you. It was all very beautifully depicted.
Thank you, sir. Thank you for your comment. So in brain,
mostly in the young women also. Like what exactly is the main reason of that, and how we can get cured so that we don't get cancer till our last breath and all that. And how few people never get cancer and how few people just get cancer even very small age. And what is the main reason behind this, like the breast cancer and the cervical cancer in the women stage?
Very nice question and good question actually. I tried risk factors, but they don't get the tumor. And somebody who is a non-smoker, teetotaler, suffers from malignancy. Cervical cancer incidence, fortunately, is going down in our country. We have now data from AIMS, especially AIMS National Cancer Institute, which is showing the cervical cancer malignancies incidence is coming down slowly. And now the breast cancer is the most common malignancy in female, not the cervical cancer. Maybe HPV vaccine, maybe the hysterectomy is being done, lot of education, awareness, better socio-economic status is probably responsible for this. So your question, why breast cancer has become common? So I think this is basically more associated with the lifestyle changes probably which is happening, especially in urban areas, because breast cancer is a disease of urban areas as compared to our rural population. So if we see why the breast cancer happens, it's basically a disease associated with female hormones. If our female body is getting more exposed to the hormones, then obviously the risk of cancer increases. So early menarche, then late menopause, and why menarche is happening early in the girls, so nobody has a very clear idea. Again, maybe the use of plastics, which as the kids, the children are playing, the hormonal issues, which probably increases, making the menarche coming early. So more the female body is getting exposed to hormones, more is the risk. Secondly, as
these kind of non-surgical treatment, and they are just also like helpful in these kind of cancers also, like if I say Botox, fillers and these kind of mesotherapies.
No, they are not there for the treatment of
until they are
cancer.
surgical.
No, we have a surgical oncologists with us, but they are not used for cancer treatment, these therapies.
No, my question is that like the Botox and fillers, they are the main factor for the cancer and all, or like there is like the normal thing?
Might be the chemicals might be associated, but will not say that there is definite proof.
Researched on a lot of papers regarding Botox and fillers. These have never been carcinogenic as per the literature. There is no evidence-based medicine which suggests that they are carcinogenic. Botox, basically, it functions over the neuromuscular junction, and it just knocks off the receptors. And fillers is basically hyaluronic acid, which is also integral part of our body, and they are actually manufactured in such a way that quite a lot of quality control is there. So they have not proven to be carcinogenic. They just fills up the gaps or the lacunas which are there, and they are just absorbed as per the enzymes in the body. And Dr. Tucker, it was a wonderful presentation. Thank you, Dr. Kaman has mentioned, very lucid and very simple. I had a couple of questions for you. You know, our eye is a very small area as per the body. What is the precision, the minimum precision of your stereotactic radiations that you can go in?
See, we aim for 1 millimeter. Also take the margin for subclinical disease and margin for our setup errors, our positional errors. So in stereotactic radiosurgery, by principle, there cannot be any error in patient positioning. Then only we can deliver such a high dose. So the room of error is very less if we have to deliver this treatment.
And regarding that, we have in our LASIK and all, there is an eye tracking devices, which is, with the fixation of the patient. But I doubt whether you guys do the fixation. So how do you manage those intraocular melanomas, and how do you deliver that precision, because the eyeball will be moving?
So for orbital tumors, very simple, traditional, the best way is we ask the patient to fix the, because we put, as you have seen in Hyderabad probably, we try to put the micropore and all so that the patient eye is always open. So eyelids, we try to pull it up. Because if eyelids, patient is blinking or patient has closed the eye, this skin of the eyes increases the dose to the cornea and can lead to corneal ulceration. As far as the movement is concerned of the eyeball, we ask them to fix the gaze on the roof and don't rotate at all. So this is probably a very effective way to manage motion.
But some of the patients with,
as you told, adenoid cystic carcinoma are very resistant kind of tumors. Sometimes with such a high doses, there is residual relapse happening. Yes.
And to the best of my knowledge, we don't have brachytherapy in the Tri-City.
Not orbital brachytherapy, and then otherwise Hyderabad patient.
Basically, Hyderabad AIMS also Bhavna is left.
So Hyderabad usually or Chennai.
Thank you, Dr. Wonderful.
Still used in a protocol or trial setting. It has not come in a routine clinical practice. Alzheimer's disease, even Parkinson's. Parkinson's, they try to find out a focus and ablate it with radiation therapy. But in epilepsy in a routine setting. Usually protocol basis it is given.
Patients of getting the normal tissue destroyed or burned is getting less and less with these latest advancing techniques of radiation therapy being used as such curative before the surgery, with the surgery or after the surgery to destroy the original tumor tissue or as palliation is becoming definitely more and more acceptable with the patients with these latest techniques and trends. We are very thankful to you, Dr. Sajal Thakkar, for coming all the way from Mohali and updating and enriching us with such a good talk presented in a very, very nice way. I'm also thankful to all the audience, all the doctors, everyone present here for sparing their valuable time and for being a very patient audience. It's time to felicitate our guest speaker,